Welcome everyone, it is great to see you. Today we will be covering hypoplastic left heart syndrome, also known as HLHS. HLHS results in a left ventricle that is unable to pump blood to the rest of the body due to deformity of the left ventricle, valves, and great vessels. If left untreated by surgical intervention, the right side of the heart literally works itself to death, attempting to provide the body enough oxygenated blood to survive. A diagnosis of this type of cardiac anomaly used to be a death sentence. However, with research, medical and surgical advancements and the dedication and hard work of the medical professional team supporting the patient, life is now an option. Among the various types of congenital heart defects, HLHS is one of the more complex anomalies, affecting approximately 960 babies in the US each year. Although the cause of HLHS is unknown, some of the accepted postulations are as follows. Most likely, the primary abnormality occurs during aortic and mitral valve development. During cardiac development, adequate blood flow through a structure is largely responsible for proper growth. With little or no blood flow, because of aortic and mitral valve atresia, growth of the left ventricle does not occur. Similarly, growth of the ascending aorta does not occur because of lack of left ventricular output. Premature closure, or absence of the foramen ovale, represents another theoretical cause of HLHS. Because it eliminates fetal blood flow from the inferior vena cava to the left atrium, fetal pulmonary blood flow is not sufficient for normal development of the left atrium, left ventricle, and ascending aorta.
What does the heart look like?
HLHS is primarily characterized by grossly underdeveloped left ventricle and ascending aorta, in addition to any of the following: aortic and/or mitral valve atresia, hypoplasia, or stenosis. These features can be seen in the following illustration. In some patients, an ASD may be present as well. The malformations on the left side of the heart render it useless. Therefore, the right side of the heart is responsible for the pulmonary and systemic blood circulation. In utero, this is not a life-threatening disorder. However, postnatal circulation is when HLHS becomes deadly. In babies with HLHS, mixed blood from the right side of the heart travels up the pulmonary artery, and either pumps across the ductus arteriosus to the aorta, or follows the normal path into the lungs to become oxygenated. The blood which crosses the ductus arteriosus flows into the hypoplastic, or narrowed aorta, then, to the rest of the body. Due to little to no blood flow out of the left side of the heart, blood returning to the heart, from the lungs, needs to pass through the foramen ovale, or an ASD, and deposit into the right atrium for further circulation. The irregular blood flow creates additional problems, including resulting in the following. Historically, HLHS went undiagnosed during prenatal ultrasound scans, because of the lack of concentration on cardiac anatomy. However, a recent increase in use of routine, prenatal ultrasonography, and examination by obstetricians, of the four-chamber anatomy of the heart, to ensure its normalcy are likely to identify HLHS more frequently than in the past.
When is HLHS often identified?
Typically, identification of the cardiac anomaly takes place during the second trimester. This is of great importance, allowing for proper education of the parents, as well as adequate planning and quick intervention of the hospital staff during delivery and post-delivery care. If the heart condition is not identified prior to delivery, there are signs, symptoms and tests which can help aid in the diagnosis of HLHS. When the baby is first born, they may appear normal. However, over the first few hours, Up to the first couple of days of life, the signs and symptoms will begin to appear. These may include cyanosis, lethargy, weak pulse in the extremities, shortness of breath, poor suckling or feeding, pounding heart, and rapid breathing. During physical examination, additional signs may include an enlarged liver, an elevated heart rate, and irregular heart sounds or murmur. If the foramen ovale and ductus arteriosus begin to close, the infant may go into shock and die. Signs of shock include cool and clammy skin that may appear pale or gray, weak and rapid pulse, abnormal breathing that may either be slow, shallow, or very rapid, dilated pupils, and lackluster eyes that seem to stare. If an abnormality is suspected, the doctor may request tests to be performed on the infant.
What type of testing should we expect to see?
Common tests may include cardiac catheterization, ECG, echocardiogram, and chest X-ray. ECGs and chest X-rays cannot diagnose this type of cardiac anomaly. However, there are findings in both tests which are consistent in patients with HLHS, therefore, are used for the inclusion of the syndrome. Findings in the X-ray are similar to those found with congested heart failure, such as an enlarged heart, increased pulmonary vascular markings and occasionally pulmonary edema. The echocardiogram is the test of choice for diagnosing hypoplastic left heart syndrome. Not only can the cardiac structures and blood flow be seen clearly with 2D viewing, but the option to use color Doppler is an important and valuable tool as well. Due to this type of non-invasive screening, cardiac catheterizations and angiography procedures are no longer the primary tool used for HLHS diagnosis. Additional lab tests such as CBC count, electrolytes, pancreatinine, liver function tests, and karyotype, provide valuable information and are often performed during the diagnosis of HLHS as well. The values obtained during these tests will help to rule in or out possible conditions that could be causing the signs and symptoms the infant is presenting. Some of the differential diagnoses include if prenatal diagnosis was not made, the survival of the infant depends on a quick and accurate diagnosis. During the first couple days of life, the right side of the heart works very hard trying to pump enough oxygenated blood to the lungs and the rest of the body. The natural closure of these ducts will result in death of the child. Once the infant has been properly diagnosed, appropriate care can be given. Currently, there are 3 choices which can be made: comfort care, a 3-stage cardiac surgery, and heart transplant. The choice to go with surgery or transplantation can depend on the severity of the anomaly and the recommendation of the cardiac specialists based on the infant's condition. The options are discussed with the family, including the advantages and disadvantages to each. During this time the infant is kept stable until a decision has been made. If comfort care is chosen, it is important for the family to receive strong emotional support from religious figures or hospital support staff if requested. However, if either of the additional options are chosen, the infant will immediately receive doses of prostaglandin E1, to keep the ductus arteriosus patent. Depending on the severity and need, the infant may be placed on mechanical ventilation temporarily. The administration of sodium bicarbonate helps the body to compensate during this time and is an important part of managing the imbalance. Due to the already decreased pulmonary vascular resistance and increased pulmonary blood flow, oxygen administration is not recommended. Additionally, the PO2, PaCO2, and FiO2 are carefully monitored. Acceptable values are as follows. The slightly higher PaCO2 will help to increase the pulmonary vascular resistance. The FiO2 range can be achieved by the addition of nitrogen, or carbon dioxide, to the infant's inspired gas via the endotracheal tube or hood. Currently, there is a 3-stage surgical process which can be performed on the child with HLHS. The first surgery is called the Norwood operation, which takes place within the first few days of the infant's life and consists of building a new aorta. The second surgery is the Glenn shunt, or Hemi-Fontan, procedure and is performed between the 4th and 6th month of life to connect the superior vena cava to the pulmonary arteries. The third surgery, called the Fontan procedure, is typically performed when the baby is between the ages of 18 months to 3 years of age. During this procedure, the inferior vena cava is then connected to the pulmonary arteries leading to the lungs. The right ventricle no longer pumps blood to both the lungs and body, but now just to the body. Heart transplantation is another surgical option. The infant must remain on prostaglandin E1 infusion to keep the ductus arteriosus patent while waiting for a donor heart to become available. The following are statistics regarding HLHS prognosis. Our role, as the respiratory therapist, is critical in the life of the infant with HLHS. Regardless of when the diagnosis of the cardiac anomaly is made, we play a part in their care. Our journey may begin when we receive the phone call to assist in a high-risk delivery, or it may start when the signs and symptoms appear in the patient. Our skills as a respiratory care professional will help in assessing, identifying, and treating the infant accordingly. Along with the doctors, nurses, and other technicians, we must work together to provide the most effective care possible. Educating, comforting, and supporting the family is very important as well. 30 years ago, the mortality rate was 100%. Today, with the medical research and advancements, the surgical and transplant options have allowed for more than 70% survival rate. Great job today, everyone! We covered quite a bit of detailed information and you asked some exceptional questions. Thank you. I have one more thing on the class agenda for today. I recorded the TV show, A Baby Story, for you all to watch, because there was a case on there involving a baby with another type of congenital heart malformation. Pay close attention, and be sure to take notes, as I will be testing you on this later.